This is United Medical ACO weekly event, and my name is Kemal Erkan. I'm the chairman of United Medical ACO. So we have our vaccine updates, but let's just actually bring up a couple of our intros and we'll start from there. So we are going to look at the COVID-19 numbers and updates, vaccine updates, and the triple aim, lower cost, better care, and then see how we are able to do. So usually you do the vaccine side, so we can start with you.
Yeah, we can go through some of, as Kemal mentioned, just some of our routine updates right now, keeping track of the latest vaccination rate for the United States as well as locally here in the state of Delaware. In the last few weeks, we can take a look here at the rolling average for our doses per day. On average, we're actually starting to continue to see an uptick in the trend here. So something we have been keeping an eye on this, or the reason we've been keeping an eye on this is to still make sure we're taking aim towards that 75% of the population being covered, that herd immunity level that we're striving to reach here, as well as in Delaware, really in worldwide when it comes to battling the pandemic. So at this rate, this current uptrend in the vaccination rate, we're still looking at another 6 months to get there. So early 2022. So Delaware, we want to take a look at the actual percent of people that are covered versus the average rate of new cases, and that is in per million. So we see on the bottom a slight trend upwards in the 7-day average of new cases, and that is kind of correlated here with our percent of people that are covered or populated in here in Delaware. So we're just under 60%, which is still a slight increase. We're increasing a little bit every single day. But that certainly has tapered off. So it will be interesting to see how that, if we start to see maybe an increase in that trend as we see cases start to rise again.
So with the vaccine updates, so I think we are at a point where we do see a lot of people who either are already vaccinated, like us and my dad, and then there's now a group of people who are opposed to vaccination. Right. And now some people see this as propaganda, and they think that we are trying to get everyone vaccinated. So you and I, we don't get paid by the government, right?
No, not one bit.
No, actually, vaccine is given for free. We do charge for the admin fee for a couple. I think it's like $10 or $20. I don't know. And if they are not insured, then we are not charging. Right. So there's no cost. And we hit this point where we were expecting vaccination numbers to get to 75% by the time it was July. So, and I was one of the maybe first ones who challenged that number because I knew that vaccination numbers was going to go down. In fact, we exercised those in our sessions. And if you remember, we said, okay, now this July is being pushed to November and December. And now we are looking for early 2022. And in the meantime, as we kind of spent a good amount of time last week, there is the Delta variant, which actually is more concerned than any others before. And then vaccination becomes more problematic. And in the meantime, what we see is with the kids and young adults, we see this new cases being, which is actually, I guess we predict that, we could predict that from the beginning because most of the people 65 and over, they're already vaccinated. So cases are going to be a lot less in that group. But now we are seeing cases being surged in the pediatric population. And so what do we have here, Tanner, so that what can we say from here?
Yeah, No, I think you hit that spot on, Kemal. I think what's really important, or what the note of concern here is, that we're seeing large numbers or large pockets of new positive cases growing in the pediatric population for just that very reason, due to the, as highlighted here, the hyper transmissibility of the Delta variant that we're seeing. We're seeing it spread much quicker in those populations that are left unvaccinated. And largely, as we know, these vaccines are currently approved for our 16 and older for the Pfizer, and then 18 and older for the Moderna, as well as with the Johnson & Johnson vaccine. So this is largely an unvaccinated and kind of a vulnerable population here. So that's why it's increasingly important for those who can get vaccinated to get vaccinated when they can, to help reduce the transmissibility of the Delta variant. The less people and the less hosts that the virus obviously can spread to, less chance of it then passing on to someone who could be vulnerable, or as we've talked about last week, gives us more of a chance to reduce the amount of variants that we do see come out of COVID-19, which is the point here that we just brought up too. So really the goal is to reduce transmissibility and reduce the amount of spread, reduce the amount of infections, therefore reducing the chance of the virus to mutate.
Yeah, I think the other news from Florida is with the younger population again.
Yeah.
That's also kind of concerning, if you want to cover that as well.
Yeah, I think this is just really highlighting that previous point that most hospitals, and what we kind of see here is this not just in particular, Florida obviously being a hotspot right now, but this is certainly something that we're seeing a trend across the nation. So Delta is definitely getting to the younger unvaccinated populations, and it's not just necessarily something that they're able to be brushing off, but we're seeing an increase in hospitalizations for this population as well, which is concerning. So just from some of the headlines that we're seeing right now from coast to coast are what we were pulling to kind of highlight this trend. So with the unvaccinated population and the youth population, and then some of these populations here that like 18 to 35 who are typically seeing some of the lower vaccination rates, they're definitely getting hit the hardest right now.
Yeah, I think this becomes more problematic, especially now in August, because the schools are going to be opening in a couple of weeks.
Mm-hmm. So that's a great point.
If we want kids to go back to school, and I know many parents are, although they love their kids, but I think they are ready to send them back to school for full time. So in order for that to happen, they need to be vaccinated. With the way that we have right now, that is not happening. In the meantime, we have a research study came out from American Academy of Pediatrics. So we do want to share that with you guys as well. And that is the new study. The data is available as of 7/29. So Tanner, what do we have?
Yeah. Well, this was interesting. This was something we, as you all know at this point, we have regular meetings as well. This, of course, being a little more community-based for our patients and for our employees, for some of the updates that we are regularly discussing and talking about internally, as well as with our providers and our clinicians. So this is something that Anthony had brought up yesterday, and kind of just highlighting the trends we are seeing in the new cases, increased trends of cases in our pediatric and our younger populations. So typically prior to a lot of the data coming out of the Delta variant, we were seeing that children were representing more of a lower percent of total cases or of all cases thus far. So since as COVID has changed, it's mutated, we're seeing increased transmissibility with the Delta variant. And amongst this unvaccinated population, we're actually seeing an increase of the overall total amount of cases that they're representing. So that's what this study is actually highlighting. It kind of gives a summary of the findings. I think it looks like it went from children were representing about 15 or just under 15% of all cases. And now you would think then in that you would think that the new case rate, they'd represent just about the same, but they're actually just about 5% more at 19.
5 percentage point more. So that's actually,
right.
So now it's 19, right?
Mm-hmm.
So it's from 14 to 19%.
Right. Yeah, and that's just over, we're seeing that increase, that just under 5% increase just over the past few weeks. So as you mentioned, with this population certainly getting ready to head back to school over the next few weeks, where there's only going to be more gathering, larger crowds, more transmissibility, this is certainly something to keep an eye on.
So now there are some symptoms specific to the kids. Is that what we are understanding from here with this study from England?
I believe so. There are some symptoms certainly specific or seen much more frequently in the cases of these pediatric COVID cases. But the other thing I think here that's important is the length of a lot of these symptoms seems to be a little longer, or they happen to have much more lingering experience, these post-COVID long-term symptoms. And I think it goes into, we have some of the symptoms up here as well that are kind of accompanying the study. So this,
Tanner, one of the things that I'm going to bring up again is we used to share the Worldometer corona updates, the confirmed cases directly from here. So if you remember, like these 2 days and yesterday numbers, and first time again, these numbers are increasing again. So the 2 days ago, the confirmed cases 115,000. Yesterday it was 121.
Right.
This actually projection started going up again, and I think like when we are having those numbers in the middle of summer, once the flu season starts. Now many people think that flu season starts in December, but that's wrong. Flu season starts in mid-September. That especially for those unvaccinated people, the issue is going to be more severe. So I do want to share one of our slides that we have. Yep, that right there. So what we are actually, the pandemic now is the pandemic of unvaccinated population. So 99% of the cases, 99.4% of the hospitalization, and 98.7% of the deaths are coming from the unvaccinated population. So this is, I think the statistic is extremely strong. So, and all we can tell is you really need to make the right choice for yourself. There's another point of this mandating the vaccine. Tanner, from the beginning, you know my position on the vaccination and how much we push the vaccination. But on the other hand, we never supported the idea of mandating the vaccination. So Susan Anderson, who was part of our session a couple of weeks ago, we discussed this in the providers meetings, and Anthony Onuglu, John Donnelly, Donna Dunkel, we wanted to see if that's our position to mandate, and we never felt like if it was my decision to mandate. Now, when I guess Christiana Hospital came out last week, I actually was surprised that they were the first to come out with that. So, but then this morning I see this, maybe a rumor, but so they actually did come out last week saying that they're going to mandate, but now apparently there are some rumors that their employees are not really happy with this.
Yeah, I believe it was the end of last week. They had announced that it was going to be mandatory for all their employees, and then this was the first time I had seen it this morning as well. Obviously, like you mentioned, it may or may not be something of substance, but it's certainly something to take interest in, because I think what's curious about this case is Christiana obviously being the largest hospital system in the state, and being certainly centered around individual or patient care, patient interaction. There are a vast majority, especially what it mentions here is their nurses who are going to be interacting with their patients. I think that's it starts to kind of raise the question on, and it's something that's already been debated, and of course is, as I get my light turned off, but it's something that we've already been debating, like if are these people or professions that are going to be in the clinical setting, like are they the ones that need to have a mandate if a mandate is going to be something that would be necessary?
So other than clinical people, there are a lot of business people there, and
right.
Christiana being one of the biggest employers of the state, they were kind of early on that decision. So I don't, like United Medical is not planning to do that, although we are a big advocate for the vaccination, and we supported the vaccine, and we are supporting the vaccine, and we are pushing the vaccine agenda. Yes, we are pushing it. If there's an agenda, we are pushing it. All those haters, they can take it that way. So because it's the right thing to do.
Yeah, I agree.
But in the like while we are saying that, we are also, I personally don't believe that I can put my signature on some mandate from the employer yet. I don't believe I have that right. So, but this doesn't mean that there are other precautions that you can take to protect what needs to be done, because there may be some reasons that people are not able to take the vaccine. So,
certainly.
But I think if there is good data, good statistics given, people will be following and understanding this.
Yeah, so, I think that's spot on, and that's what we're trying to accomplish here. Just making sure that that information, the statistics, and the data around that, and the facts are certainly shared.
So we wanted to discuss a little bit about the value-based contracts. So this is important for our providers. It is important for our patients. It's important for our employees. Pretty much it's important for everyone who's part of United Medical ACO. But we want to give some feedback, some background on this issue. And I know, Tanner, we were discussing this last night, and you had some questions, and we can actually go through those. Now, this all started with the Medicare shared savings, which we call them MSSP. That was our main ACO, Medicare MSSP. So after that, United Medical actually had like 5 other ACO contracts with Highmark, with Medicaid under the 2 other managed cares with Health Options and MeriHealth, and then Humana, which is a Medicare Advantage group, and also United Health dual plan. So now I was explaining a couple of these, and some of our challenges and why we were not happy with some of the program languages, like how they're actually designed and who designed them, and how it's measuring the quality and the outcome, and if it's accurately measuring it. And because these are all public, so when I was explaining this to our team, I kind of felt like if I was complaining and just giving them excuses. So I just kind of wanted to bring up this issue and understanding what difficulties are that we are dealing with. So now, many of you heard the term triple aim. The triple aim is with the lowering costs, increasing the quality for better outcome, and increasing the access. So United Medical is doing all those. Plus, we also make sure that our providers are happy. So we have this quadruple aim, rather. But when you see this, you may say that, well, why is he actually sharing this slide? So it was 2017 when we got our first MSSP results. Although we were the least expensive ACO, MSSP ACO in the state of Delaware, we didn't have the positive return. So now maybe I'm just going to repeat that. So we were the least expensive, so lowest cost. Quality-wise, we were all similar for ACOs. We were similar for Medicare, and we didn't make it. And I'm like, why? What? When we are the least expensive, why didn't we make it? Well, we kind of knew why we didn't make it, because there is a minimum savings rate. So minimum savings rate is, so you have to be better than yourself. So everyone is competing with themselves, their own. Like, so let's say, so I'm heavier than you are, right? My BMI is higher than yours. So since we have the Bariatric Friday coming up, so we can just have the we can get it ready. So my BMI is 28.5. Yours is 24, just for this example. For you to lose 5 pounds versus for me to lose 5 pounds, for me, it's easier. So when I lose 5 pounds, I get rewarded. When you lose 5 pounds, it becomes more difficult, right? So minimum savings rate is something that's set so that you have to be better than yourself. So now that was our biggest challenge. Although we were the least expensive, I don't want to say we were the cheapest because it sounds bad in the cheap sense, but we were most efficient, least expensive. And then in order for us to make it, just for those who still have memories from school, so we were A students. So in order for us to make any return, we had to be A+. But there were some losers, if you were like a C- student, you could just go to C+ and still make a big return. Now, for those who might have read my article from 2017 regarding the MSSP outcome for 2016, no ACOs left behind. So there were some there's no F-, I guess, Tanner, so, but it's just F. I hope there's no F-.
I really wanted to highlight how it was the worst one of the rest.
So there are some ACOs that they were horrible with their cost, but then with this little bit of improvement, they could just go to C- and they could make millions, and they did. So we kind of learned this in a hard way that, okay, so being better than yourself with the benchmark, historical benchmark that you have. So it was a challenge.
So yeah, I can certainly see how that would lead to challenges for the United Medical ACO in this case, being at the low cost end. It certainly sets a challenge for the improvements year over year. So I guess then the question would be, what sort of behaviors or any kind of new behaviors, new workflows, what has the United Medical ACO been able to do to kind of help address some of these challenges?
So, I mean, again, the main thing is what we have done in the last 5 years, how we were able to mature the ACO. One is like we have to deal with the reality. So there are certain things we cannot change. So I just send you something from this morning for us to share, because when you don't see them, you don't really understand. For our people, this is a real patient's chart. And now there are some people who are watching these every day. So, I mean, every week, and I'm actually sharing this for them. But look at this one. This patient is in and out of the hospital, and then we see them every time they're out of the hospital. Hospital follow-up, hospital follow-up, hospital follow-up. This is a scheduled visit, hospital follow-up, hospital follow-up, so on, so on, so on. So I'm responsible for the cost of this patient. Now, this patient is in the hospital for so many times, so much cost, so much work that my PCP has to do, so much reach out, but the patient's in the ED all the time. Now, all we want is, well, hospital, let's give you this model of hospital PCP models. Since you are already seeing them in the ED, take them over. This patient would benefit from it because we cannot manage them because you are seeing them in the ED all the time. So you should take this. Now, I'm kind of taking a little detour from your question, but we had to learn how to deal with these and manage these during that time in the 5 years. So this was one of the challenges that we have. But we also needed to manage these in some sense that we have our case conferences. So these are daily case conferences now. We spent a lot of time initially for the, just going into more specifics, maybe like there's the risk score. And not every dollar that we spend is the actual dollar that we are responsible for. It's the risk adjusted. So you may be spending $10,000 on a patient, and I may be, based on how we are reporting it, based on the diagnosis.
Right.
And your 10,000 may be more or less than my 10,000 after the risk adjustment. So now we had to master that, and we still have a lot of work to do on that side. But maybe a couple of the contracts, the only reason we were able to make a good return or some return is because we were able to educate our providers. And from our central office with our nurses, we were able to catch some of those discrepancies ahead of time. But now we are actually taking the game to a next level because we want meaningful impact on the patient's outcome. And that only way that we can do is if we are able to have a good way of, this is from our population health system that we designed.
Yeah, I was going to say, definitely. I know you mentioned case conference, and just for someone who might be listening is not very familiar with the case conference, I know just from being part of the business development team and seeing how the team and the nurses all work together and how this is all managed through the population health system or QuickBase. Could you just kind of go into a little bit about what exactly we're seeing here, what these different line items mean, and how this all works together and how the team works?
Sure. So from the case conference, we are able to actually, from our patient population, we are able to identify certain patients who may need more help from the central office with the nurses. Now, we also ask our providers to send those patients to us if they can identify them ahead of time. So between the two, either we pick the patients based on their risk level, or providers are sending them. Because the question, what you are asking, the reason why we need a case conference is because the stuff that you do with the visits and with the risk stuff, they may not be so meaningful for the patient, because when you are trying to improve someone's care, it's not just what you are prescribing, what orders you are giving them, but understanding where they live, who's supporting them, what difficulties that they're having. Are they able to refill their medications? Are they able to follow up with their specialists? Do they have access? So all that actually is important for us to reach out and provide for the patients. So like there are patients with Parkinson's disease. So if we treat this patient just like any other patients, we are calling you to follow up on your cardiology appointment. Well, the patient has a Parkinson's disease. So that means I'm not going to mainly talk to the patient. I'm going to talk to the caregiver of the patient, right? So if we cannot make those separations, then we are not going to have a meaningful way of making that impact. So patient has Alzheimer's. So then what I'm providing is not going to be the same. Patient is about to go to hospice service. So then I have to take a different approach. So now this becomes the multidisciplinary approach of, okay, how we can change our culture of providing the care. So it's not just the standard primary care anymore, but it's the adjustment that we have to make on the care delivery of what we are doing. So then our nurses can actually reach out to them. We can talk to the children of the elderlies, or caregivers, or the other specialties. There are several different ways to approach them. So, and it does, so far, it is working for us, because instead of trying to fix 10,000 patients, because not every patient needs you at the same level, there may be 500 patients that you can actually make a meaningful impact. So in order to do that, you do need a good database to help you, and you need to have a daily discipline, which what we call case conference. In the case conference, we have our nurses, we have our directors, we have our business development, myself, and we are communicating with our providers and patients directly. We spend 1 hour in the case conference altogether. There are usually about 10, 12 people from our teams. And we do go through the system and just help each other to see what these patients need. Like this patient needs bariatric consult. We put that and communicated with their PCP, behavioral health, nutrition, and endo. Like this patient could have endo before, but they didn't. So, or maybe they refused, who knows. And then patient is already on metformin, but we believe that endocrinologists can help this patient better in some cases, because if they're not responding, because based on their A1C and other results, maybe it's time for this patient to be seen by the endocrinologist. And this is where we are actually adding someone to the care team. And these are all add-ons to the team. So then we are kind of helping the primary care in the sense that, okay, now they can actually have more help. In some cases, they want to do everything, but they are not able to because they don't have time. They are not able to because they don't have all this expertise in those specialties. So who can help the diabetes the best, if it's an uncontrolled one, is the endocrinology. Who can help the obesity best is the bariatric surgeon. So nutrition is something that standards should be given to everyone who's having difficulties with diabetes and obesity issues. Behavioral health, a lot of patients are having access issues. So we have a social worker, so they can actually help them with the access. So this is kind of like how we are able to coordinate the care through the case conferences. Now we have a similar approach in our bariatric program, and that's how, this is, Tanner, this is really important. So when we say something that's kind of like settling or maturing in both sense. So we started the bariatric program so long ago, but in 2012, we took a different approach. And our database we started using in 2012. Although we have our EMR, we had to use something differently to be able to better keep track of the follow-ups, because the patient needs so many different things. And this is the example that you are sharing. Now, what we learned from the bariatric, we were able to actually put it on applied on the ACO side, but this is something that's coming from our bariatric program. So each patient gets cardiology, and then their initial visit, their second visit, once they are cleared, the pulmonary, their EGD, their psych visit, their PCP visit, their surgical clearance, their home sleep study. There's an add-on. This normally we don't have rheumatology, but for this patient there is. But to be able to keep track of them, there's a patient takes anywhere from 3 to 6 months. And remember, like 35% of those patients drop out. But we took this approach and then we applied this to our ACO. So we are able to build something more on top of what we learned from the bariatric side. And it does work already. In fact, like this morning when we went through all the patients who were part of the program, in a short amount of time, we built enough number of patients. Now we weren't able to, first time this week, we were not able to finish all the follow-ups. So we had to stop assigning new patients for 1 week and then finish the rest of the follow-ups. So the main focus is not just some number the crunching and just punching the numbers and putting the numbers and increasing the risk. It has to be meaningful. So you have to be able to measure what changes are happening. So, and I think we are on the right direction from that point. So now the new MSSP scores are the results are going to come up in the next couple of weeks, and we are hoping that we'll be in a good place. We don't have the numbers yet, but everyone will be getting their numbers in the next couple of weeks, and then we'll be able to share those with all of our people. Our goal is to support our providers mainly, as we are the advocate for our primary care, but our primary goal is to support our patients at the best level that we can. So that's kind of our goal for what we are doing. So we have the bariatric event coming up at 1:15 with Dr. Erkan. And that's what we have for today. So Tanner, did you have anything to add before we close?
I think that is really important because it really highlights the multidisciplinary approach that you've mentioned. It was something we talk about in the bariatric events. I'm sure whoever's been listening to those as well has heard it numerous times with that process. And I think that the CASE conference really highlight that. It's really cool to see, just from my perspective, when these types of updates are given in our provider meetings and our special sessions. It's cool to see just how each of the different pieces work together, because it truly is a big team effort. And at the end of the day, it's not just showing numbers or like having the data when it comes to these patients, but it's real people and it's real stories. So the ACO is really working hard to really push for a best outcome for these individual patients' health. And it's truly taking a whole team, and it's really cool to see it all work together. So I thank you for going into that a little bit, and I hope people definitely got a little bit out of
we'll follow up some of those updates once we have the final results. And
yeah, I think that would be good.
I think it's also good, every little bit more information that we can put out there. It's important for everyone to know. And thank you for putting everything together. And vaccination, we support, we push the vaccine out there. We don't believe that mandate is the right approach, but we do believe that vaccination is the right way to go. Please be responsible and get vaccinated. Thank you. We'll see you next week. Bye-bye.